Okay. All right, let's get going. So the title is more than what was advertised. Um, I can be a little bit verbose, and here's an illustration thereof. The real title is The Continuing Conundrum and Difficult Diagnosis of Etiologically Elusive, Idiopathic Multicentric Castleman Disease. But even that's a little bit too brief for my liking, so I have a subtitle of Clinical Clues, Puzzling Pathophysiology, Histologic Hallmarks, and the Morbidity and Mortality of this Mysterious and Malevolent Mimicker. In terms of disclosures, I am on the speaker bureau, although with limited activity for a company, Ricordati Rare Diseases. I've served as a consultant for Scopio involving digital microscopy, and I've done some teaching for the American Society of Clinical Oncology. Otherwise, I'm delightfully unemployed, having retired about a year and a half ago from the University of Pennsylvania. So this session, this talk is broken down into 5 easy pieces. Firstly, I'm going to give a little bit of background. Secondly, I'm going to talk a little bit about what we know about the pathogenesis of this disease. Number 3, I'm going to push the wrong button, but now I pushed the right button. And I'm going to spend the bulk of the time talking about how we make a diagnosis of multicentric Castleman disease. Number 4, why it's so important to reach a timely diagnosis and institute therapy as soon as possible, and conclude with a brief summary. So in terms of background, the disease or group of diseases that reflect Castleman disease is a heterogeneous group of disorders that show variable lymph node pathologic features. And there are 2 key words in this very first title slide that are worth noting. They're often overused words, but very important to highlight the fact that this is really a very remarkable heterogeneous group of diseases with different manifestations and pathologies, and certainly variable lymph node pathology. Importantly, from a classification perspective, although pathologists classify different forms of Castleman disease, the current and probably more appropriate classification approach is one that is more clinical rather than pathologic, although there is some overlap, as we shall see. So the entity of Castleman disease was first described and named after subsequently the initial describer of the disease, Benjamin Castleman, about 70 years ago in the mid-1950s. And at that stage of the understanding of the disease, it was thought to be a disease that only arose in one site, hence unicentric Castleman disease, or UCD. Excuse me. Subsequently, it was determined that the disease could present in multiple lymph nodes across the body, and hence the separation of unicentric and multicentric Castleman disease. By definition, unicentric Castleman disease affects one lymph node site or one lymph node station, one specific anatomic locale in the body, whereas by definition, multicentric Castleman disease involves 2 or more sites. More recently, and initially seemingly confusingly, is an entity or subtype of oligocentric Castleman disease. And it would seem challenging to sort of fit something in between that's 1 and between 2 and more. But oligocentric Castleman disease begins with 2 to 4 sites, which seems to overlap with multicentric Castleman disease, but is distinguished from multicentric Castleman disease in that although most patients with multicentric Castleman disease are quite ill, patients with oligocentric Castleman disease are not sick, only really manifest with the anatomic enlargement of involved lymph nodes in the body. To confuse things a little more, others have introduced an entity of asymptomatic multicentric Castleman disease, which makes things a little bit confusing. How is it distinguished from oligocentric Castleman disease? Well, it involves many sites, quote unquote, but more sort of specifically in distinguishing these 2 subtypes. Oligocentric Castleman disease, when it involves 2 or 4 anatomic sites, they are usually regional sites in close anatomic proximity to one another. By contrast, asymptomatic multicentric Castleman disease is much more widespread. Also worth pointing out, although we're not going to spend much time talking about unicentric Castleman disease, although it's thought to be just due to the mass effect of the lesion, about 1 in 5 patients can actually be symptomatic in addition to the mass effect. Some of these patients may display multicentric Castleman disease-like symptoms and inflammation, as we'll get to shortly, bronchiolitis obliterans, paraneoplastic pemphigus, which is a bit of an odd term because this isn't really thought in 100% of cases to be a neoplasm. Amyloidosis, autoimmune hemolytic anemia are things you may see in patients with unicentric Castleman disease. And another interesting feature distinguishing unicentric Castleman disease from multicentric Castleman disease is that the lymph nodes, although isolated, tend to be more prominent, the lymphadenopathy. So typically in unicentric Castleman disease, they're quite chunky lymph nodes, more than 5 centimeters in size, whereas in multicentric and oligocentric Castleman disease, they tend to be, although disseminated to variable degrees, smaller in size. Okay, focusing now on multicentric Castleman disease. This comes in 3 broad flavors. That which is driven by human herpes virus 8 or Kaposi sarcoma herpes virus, seen predominantly in the setting of immunodeficiency and also allied to that in the setting of HIV. There's the POEMS-associated multicentric Castleman disease, a group of disorders associated with this acronym of P for polyneuropathy, O for organomegaly, E for endocrinopathy, M for monoclonal gammopathy, and S for skin changes. And then having excluded those 2 forms of multicentric Castleman disease, one is left with idiopathic multicentric Castleman disease. Idiopathic multicentric Castleman disease, accounts for the majority of patients with multicentric Castleman disease, according to most studies. POEMS syndrome also important to note that not all of the patients actually have, with POEMS syndrome, have Castleman disease. In fact, a minority actually have the diagnostic features of multicentric Castleman disease. So there's not a one-to-one relationship between POEMS syndrome and multicentric Castleman disease. With regard now to the idiopathic form of multicentric disease, there are now recognized 3 subtypes, which I'm going to expand upon further. There's IMCD-TAFRO, TAFRO standing for thrombocytopenia, as opposed to the more frequent thrombocytosis, as we shall see in Castleman disease. A for anasarca, F for fibrosis and or fever, F for reticular fibrosis or renal dysfunction, and O for organomegaly. And then there's NOS, idiopathic multicentric Castleman disease. More recently formally added to the classification scheme, although it's been recognized for a few decades, is IMCD-IPL, which stands for idiopathic plasmacytic lymphadenopathy. To add to the acronyms, PEST is often associated with POEMS. PEST stands for papilledema, extravascular fluid connections. S for sclerotic, as opposed to the usual lytic lesions one might encounter in plasma cell neoplasms. And T for thrombocytosis and often erythrocytosis as well. According to some studies, and not all studies, and I'm not sure if this is universally accepted, but the idiopathic plasmacytic lymphadenopathy is believed in some to be the most frequent and account for up to 45%, but I don't think this is agreed upon by all studies. So now to get rid of all the sort of fluff in the background, and if we just focus on the classification scheme as illustrated here, what I'm going to focus on primarily today is to discuss idiopathic multicentric Castleman disease with few, if any, references to the other entities. It's important to, however, appreciate that there is a substantial difference, as one might anticipate, in the different clinical forms of Castleman disease. The red line showing the median survival or the survival over years in this Kaplan-Meier curve of unicentric Castleman disease in red, not too shabby. At the bottom, idiopathic multicentric Castleman disease in blue, very poor outcomes, as we shall expand upon, and in between oligocentric multicentric Castleman disease in green. The epidemiology of multicentric Castleman disease with regards to incidence and prognosis, it's certainly not a major public health menace. It's a rare disease, but it's a potentially life-threatening one. And in the United States, only roughly 1,000 cases were documented when studied extensively in 2018, 8 years ago. More recently, it's believed there are roughly between 1,500 and 2,000 new cases diagnosed per year. But poor familiarity with the disease can lead and often does lead to delayed diagnosis. And despite many recent advances, it remains a serious condition, a mysterious condition with a poor prognosis, with an estimated 5-year survival resulting in death rates of between 1 in 6 and 1 in 4 patients within 5 years. Before the introduction of interleukin 6 therapies, which have modified the outcomes of the disease, mortalities were even worse, between 35 and 60% mortality between 5 and 10 years after initial diagnosis. And hence, it's very important. It's become clear that early diagnosis is important, but it's often delayed due to the complex and, again, emphasizing the heterogeneous presentation and the unfamiliarity with both the clinical and indeed the pathologic features. The prevalence of the disease, as illustrated from the study performed a few years ago, looking at insurance claims-based algorithms, showed that the prevalence disease, all cases of Castleman disease, roughly 16 per million population. So highlighting its relative infrequency. But an interesting distribution was shown in this study in that unicentric Castleman disease was shown to account for only roughly 1/3 of all patients, 5.1 as opposed to 16. Multicentric Castleman disease accounting for roughly 2/3 of patients, 11 out of 16 per million. And in this study, the minority of patients with multicentric Castleman disease appear to be HHV8 driven, whereas the majority seem to have the idiopathic flavor of MCD. This study is noteworthy for two things. Most, if not all, texts and in fact reviews have suggested and continue to suggest that unicentric Castleman disease is more common than MCD, number one, and number two, that the majority or at least a half of patients with MCD are HHV8 positive. And both of these figures or incidences show that the opposite is in fact the case from this analysis. And but important to point out that the numbers that I'm showing here were the first ones following the introduction of Castleman disease-specific ICD grading codes, ICD encoding, as well as the publication of diagnostic criteria for idiopathic multicentric Castleman disease that came out about a decade ago, 2017. So they may, in fact, be more realistic, provide a more realistic picture of the distribution of various types of Castleman disease. The presentation can certainly be very non-specific. It can present like an infection, sometimes with mild flu-like symptoms, but certainly can be a lot more severe than that. It may mimic an autoimmune or autoinflammatory disease, or may present like a malignancy, such as lymphomas. So here are some of the symptoms that a patient may present with, as illustrated here. But one particular patient, patient 1, for example, may present with fatigue, edema, weight loss, and ascites, whereas another patient with hepatosplenomegaly, night sweats, and ascites both have multicentric Castleman disease, but with very different clinical presentations. And as I've mentioned, the initial presentation might be chronic, might be mild, and can be acute or could be severe and severe. So it's highly variable. But it's a progressive disease, is idiopathic multicentric Castleman disease, which can lead to organ failure and death. Moving on to the second section, the pathogenesis of the disease. It's understood that idiopathic multicentric Castleman disease is driven by a cytokine and chemokine storm. But what initiates the storm still remains enigmatic. It's been hypothesized to be driven by one of three things, and they may all be wrong. Possibly an autoimmune or autoinflammatory disease that may or may not have a genetic basis, and that's one hypothesis. Another hypothesis is that it's a neoplasm or a perineoplastic phenomenon leading to an expansion of lymph node cells that may not be lymphocytes, but may be other stromal cells. And thirdly, there have been suggestions that it's due to an uncontrolled infection, the so-called pathogen hypothesis. There was a study done a few years ago in which metagenomic shotgun sequencing was performed on patients with multicentric Castleman disease, looking at viruses in particular, and no incriminating virus was identified. But you have these three separate or sometimes perhaps overlapping hypotheses, resulting in ultimately a cytokine and chemokine storm, which dominates the clinico-pathologic picture. Over the decades, there's been a vigorous quest for determining what the genetic candidate is for Castleman disease. And this very busy cartoon illustration here from a review article from a few years ago highlights the problem because it illustrates an abundance of different and disparate underlying genetic causes of Castleman disease, still in a minority of patients. In the majority of patients, an underlying genetic candidate has not been identified, but this very busy slides identifies or highlights some of those that have been. I will just highlight one or two. Mutations of platelet-derived growth factor receptor beta have been reported in a minority of patients, but in a couple of studies. Mutations of this gene, a nuclear co-receptor, has also been described. But again, important to highlight, we really have no idea if there is, or if there is one, what the genetic cause of Castleman disease is. I'll point you to one recent study that came out just towards the end of last year by a group at Penn. I was not associated with the group, but the first author was a fellow who trained with me. In fact, she got married yesterday, and last night I was at her wedding. Be that as it may, she did a very nice study identifying a gene CABIN, calcineurin associated binding protein, I think it stands for, that was identified in twins with Castleman disease, and she's generated a mouse model. So this may be another genetic candidate for patients with Castleman disease. It's key, and it's been understood for some time, that IL-6 is a critical driver in the majority of patients, but not all patients with idiopathic multicentric Castleman disease, with this increased human IL-6 activity leading to a number of downstream consequences, with the increased VEGF production causing the new formation of new vessels, plasma cell and B cell expansion leading to the lymphadenopathy, although as I'll point out in another slide, it may not be actual expansion of these cells, but retrafficking or abnormal trafficking of plasma cells and B cells. T helper 2 cell expansion accounts for some of the other manifestations, such as autoantibody production and autoimmune reactions, and the heightened inflammatory response accounts for some of the clinical symptoms like fever and others that mimic lymphomas, and the laboratory findings of elevated SED rate, elevated C-reactive protein, immunoglobulins, and anemia. And in severe cases, it's well known that the life-threatening cytokine storm can occur, leading to organ failure and death. IL-6 is certainly a pleiotropic and pluripotent cytokine that is central to the pathogenesis of multicentric Castleman disease and affects many organs and systems across the body, as illustrated as this in this busy cartoon. So elevated interleukin-6 levels can stimulate B cells to account for increased antibody production and hence their hypergammaglobulinemia, can act on hepatocytes accounting for the elevated inflammatory markers, can act on megakaryopoiesis resulting in the thrombocytosis, can affect vessels through VEGF production, resulting in, amongst others, angiometer formation, and can damage renal mesangial cells, resulting in kidney disruption and dysfunction. The source of the interleukin-6 is always thought to be arising from plasma cells, but whereas that is the case in the idiopathic plasmacytic lymphadenopathy variant, it's not the case in TAFRA, in which it's been shown that the interleukin-6 emanates actually from endothelial cells. IL-6 is certainly not the only mediator of the disease. It may be the conductor of the cytokine or inflammatory orchestra, but there are other factors that are elevated either due to IL-6 or independent of IL-6 that are mechanistic in the clinico-pathologic picture of IMCD. I mentioned earlier that lymphocyte trafficking seems to be more important than the proliferation of lymphocytes. So cells get sort of resegmented to different areas of a lymph node, is one recent study suggested, and maybe part and parcel of the disease. But it's still unclear of what the primary cellular abnormality that is driving the process. Yes, we know that IL-6 comes from the endothelial cells or plasma cells, but what's causing those cells to elaborate interleukin-6? Recent studies have suggested lymph node cells that we don't normally think of or perhaps didn't even know existed might be driving the disease, such as T-zone reticular cells, perivascular reticular cells, and a third group of cells that we perhaps are more familiar with, follicular dendritic cells, may be the sort of true pathogenic cells, the cells that are driving this disease. Those are the current where the current thoughts lie. Okay, so with regard to diagnosis, where we're going to be spending the bulk of the talk, it's important that immediate and accurate diagnosis be yielded, but it's often delayed for a variety of reasons. This is a rare disease, so it's seldom encountered and may be challenging to recognize for those unfamiliar with it. As I've mentioned a few times now, it's very heterogeneous in terms of its clinical presentation, and the findings are very nonspecific and can be mild with asymptomatic lymphadenopathy, chronic inflammation with generalized lymphadenopathy, but can progress or even present with severe and progressive cytokine storm. It certainly can mimic numerous other diseases, autoimmune diseases, infectious diseases, neoplastic diseases. The very hypotheses that we think may drive these diseases can mimic multicentric Castleman disease. So neoplasms such as lymphomas or FTC sarcoma, a variety of autoimmune diseases, lupus, rheumatoid arthritis, adult onset Still's disease, HLH, in terms of autoimmune diseases, and a variety of infections can present with features that mimic a Castleman disease. And then from a pathologist point of view, the histology is quite variable and can be nonspecific, and similar mimicking pathology can be seen in autoimmune diseases, in malignancy, and in infections. And as a consequence, patients are often misdiagnosed or may endure months without appropriate disease management strategy. But it's become a little bit clearer, sort of, in the last decade or so, how to go about diagnosing multicentric disease. In that a decade ago, a group got together and came up with the diagnostic criteria for idiopathic multicentric Castleman disease. And so the first step, obviously, is to establish the diagnosis. There are two major criteria that I'll elaborate on in the next and subsequent slide. There are 11 minor criteria, and at least two of those must be identified, one of which must be a laboratory abnormality, and then also very important to exclude the mimickers of idiopathic multicentric Castleman disease, ultimately yielding, hopefully, a diagnosis. But that can be quite challenging getting there. So to elaborate on the diagnostic criteria, the two major criteria, number one is multiple enlarged lymph nodes, measuring just more than 1 centimeter in the short axis in 2 or more lymph node stations, and then meeting the histopathologic criteria, which I will go into in some detail, so the lymphadenopathy and pathologic features. The minor criteria are 11, as I mentioned. There are 5 clinical criteria: constitutional symptoms, fluid accumulation, hepatosplenomegaly, eruptive cherry hemangiomas or violaceous papules, and pneumonitis, lymphocytic interstitial pneumonitis. 6 lab criteria as listed there, and at least 2 of those need to be present, and at least one of them needs to be a lab parameter to diagnose idiopathic multicentric Castleman disease. And then the third arm or third leg of this diagnosis, the exclusion of the 3 disease groups that I've alluded to before, exclude infections, HHV8, EBV, and others, exclude autoimmune diseases, lupus, rheumatoid arthritis, and others, and exclude neoplasms of lymph nodes, including myeloma, including lymphoma, and others. 2 things I want you to highlight on this rather word-heavy slide is that the criteria as published indicated that an excisional biopsy is preferred. I've added that it should be mandated. I think it's extraordinarily challenging to both diagnose and indeed exclude it on a needle core biopsy. So when we do lymph node biopsies on these patients, it really should be a whole lymph node, an excisional lymph node biopsy. A second point to highlight is that many patients with multicentric Castleman disease will have many of the autoantibodies you encounter in autoimmune diseases, but they lack the other criteria for diagnosing these autoimmune diseases. So the presence of antibodies itself should not preclude the diagnosis. A question that might well be asked, and which I am now asking, is why is interleukin-6 measurement not included in the criteria, given that it seems to be such an important driver of the disease? Well, there are at least 3 good reasons. The serum levels are not always elevated, even in patients with very severe inflammation, and it appears that tissue levels, and if there was a way to measure them, and maybe there will be in the future, that tissue levels of interleukin-6 seem to be more pertinent with regard to disease activity. And another reason is that in patients who are treated with interleukin-6 antibody therapy, if you think you can monitor the patients after initiation of therapy, you want to measure IL-6 levels, you can get spurious elevation of the protein in patients who are on the drug. So that's not a recommended way to monitor disease from a laboratory perspective. CRP, SED rate, and others, simple tests may be preferred. So the pathology of a Castleman disease, and in particular idiopathic multicentric Castleman disease, has been sort of codified in terms of how the criteria can be used to diagnose this disease. There are 5 criteria that need to be looked at according to this classification scheme, and that is A, regressed germinal centers, B, predominance of follicular dendritic cells, C, vascularity, D, whether the germinal centers are hypoplastic. So I want to point out that there are the 2 extremes, regressed germinal centers at one end or hypoplastic germinal centers at the other end, with the latter typically associated with plasmacytosis. And based upon the grading of these 5 criteria, one can land up with more hypervascular pathology, synonymous with, to some degree, but not absolutely identical with the old term, old school nomenclature of hyaline vascular Castleman disease. At the other end is plasmacytic pathology, mixed pathology in between. As I've alluded to, and we'll highlight again, that excisional lymph node biopsy is absolutely required. Provides a more global view of what's going on in the lymph node. We know that as pathologists looking at lymph nodes, and an FNA, fine needle aspiration, or core biopsy is really unlikely to be helpful and is really not recommended at all. So you may do a needle core biopsy and you've got some sort of atypical lymphoid tissue here. I can't really tell what's going on, but if you look at the excisional biopsy, you have a much more global view of what's going in this lymph node biopsy, and it starts revealing to you some of the classical features of Castleman disease that we'll go through in the ensuing slides. So we'll go through each of the 5 facets or parameters that are looked at, that are graded to yield a diagnosis of multicentric Castleman disease from a pathologic perspective. These are graded 0, 1, 2, and 3. These are semi-quantitative guides. It would be great to have a numerical guide. Some people have, if you'll read the publications, have given percentages rather than 0, 1, 2, and 3. I would urge you not to pay any attention to them. There are 2 studies that I know of that talk about percentages, neither of which is based on any data or science. They're very arbitrary. Not that these 1, 2, and 3 are not arbitrary, but they also, the 2 publications have different parameters. So it's quite confusing. So I would urge you to ignore that. So we use semi-quantitative measurements like no regressed germinal centers, few, many, and most. Not ideal, but that's what we work with at the moment. And this this grading system of 0, 1, 2, and 3 is applied to all the 5 parameters. So follicular dendritic cells may not be prominent at all. That's a 0. Very prominent, that's a 3, and they're in between ones. Similarly, vascularity may range from normal to mild to moderately increased to very prominent. Hyperplastic follicles, again, part of what one's more likely to encounter in the plasmacytic variant. Most gives you a 3, no hyperplastic follicles gives you a 0, and 1 and 2 in between. And then finally, plasmacytosis, the degree of plasmacytosis can be similarly graded 0, 1, 2, 3, normal, mild, moderate, and very increased or sheet-like. And based upon the outcome of your assessment of these criteria, and paying in particular attention to the regressed germinal centers and the plasmacytosis, if either of those yields a score of 2, you can start entering into the diagnostic realm of idiopathic multicentric Castleman disease. But that may, on the one hand, reflect the hypervascular pathology with FDC prominence, regressed germinal centers, and many of the other features that I'll illustrate on the ensuing slides. At the opposite end of the extreme is plasmacytic pathology, which, as the name suggests, sheet-like plasma cells, but here, rather than being associated with regressed germinal centers, which may be seen, but the germinal centers here are more dominantly large and hyperplastic, and vascularity is usually less of a feature. And of course, there's mixed pathology with features in between. Important to highlight that although historically one would have associated unicentric Castleman disease with, for example, the hyaline vascular or hypervascular type, and multicentric Castleman disease with the plasmacytic type, you can see all pathologies across all subtypes, including in the diseases we've sort of excluded already, such as Poem syndrome and Kaposi sarcoma or HHV8 associated Castleman disease. So here's a fairly classic low power view of a lymph node involved by Castleman disease, showing the interfollicular expansion that's very pink due to vascular expansion with widely separated small follicles. These guys have atretic germinal centers. Another key feature of unicentric Castleman disease is in particular the absence of sinuses or obliteration of sinuses, which to a histopathologist has always been associated with a neoplasm. This is not thought to be a neoplasm in the majority of cases, and yet it's associated with absent lymph node sinuses. There's a variant of this type of Castleman disease, so-called stroma-rich variant of Castleman disease. The interfollicular areas look a little bit paler. There's an predominance of stroma, as the name indicates. These patients tend to have more an abdominopelvic presentation. Here's the classic view of a follicle in Castleman disease in which there's an expansion or hyperplasia of the mantle zone cells, accounting for the bulk of the whole follicle itself. And these mantle cells are arranged in a concentric ringing pattern, giving the so-called onion skinning pattern. And there's also happens to be a regressed germinal center evident in this particular one. This shows the classic feature of the hypervascular form in which there's a penetrating vessel going perpendicularly to, in this instance, through the mantle zone, another classic feature of Castleman disease. This shows a third feature allied to the follicles, so-called twinning, in which there are multiple germinal centers in a single follicle. This particular example shows more than just twinning. There seems to be tripling or even quadrupling of 3 or 4 germinal centers in a single follicle, a very characteristic feature of a Castleman disease. This is another example of hypervascularity, with the vessels here more prominently displayed in their interfollicular regions. They're also penetrating the expanded mantle zones, but they become quite hyalinized as well, and the germinal center itself is fairly sclerosed. This shows an immunohistochemical stain performed in patients with Castleman disease. It's generally not required to do immunohistochemistry, except to exclude one subtype, which I'll get to in a moment. But this is an immunohistochemical stain performed in Castleman disease to illustrate a characteristic, not pathognomonic, but a characteristic feature. Would anybody in the audience like to unmute their microphones and tell me what stain this is and what cells are being highlighted? Looking for volunteers. Lauren, I don't see the names of the participants, but if you can, why don't you pick on somebody who you know looks at lymph nodes or should know what a lymph node shows in this slide? Any volunteers? I can't see the chat either, so if anything's coming through the chat, I cannot see it. Okay, so this firstly, it kind of the clues here as to what this is staining. This is not staining these mononuclear cells that are, by the way, not part of the follicle. So they're not B cells. Here's the follicle here. There's the germinal center there. But it's also staining these guys. And these guys are endothelial cells. So what will stain endothelial cells and also stain other cells in a lymph node? This is CD123. This is the interleukin-3, part of the interleukin-3 receptor. And this is highlighting clusters of mature plasmacytoid dendritic cells, not the blastic ones that are expanded in BPDCN, but you can see collections of mature plasmacytoid dendritic cells, non-specifically in Castleman disease, a reactive feature, but may point you to the diagnosis. Another facet of a disease that one can encounter, particularly in hyaline vascular carcinoma disease, is follicular dendritic sarcoma, highlighted by these collections of spindle cells seen here, stained with FDC markers such as CD21 or CD23. There are others, podoplanin, and it's a not infrequent phenomenon. About 10 to 20% of patients with FDC sarcomas arise in the setting of unicentric Castleman disease. It's unclear, and I don't think there are any studies that have shown what proportion of UCD patients develop an FDC sarcoma. But certainly they are incriminated in the disease. As I've mentioned, one of the criteria is FDC hyperplasia. They may become dysplastic and ultimately neoplastic as well. Another cool and interesting observation in a Castleman disease, again, in particular in the hyaline vascular type of Castleman disease, is an expansion of atypical immature lymphoid cells that do not seem to belong in a normal lymph node. When you stain them, they may mark with CD3, so they're T cells, and when you do a TDT, they are TDT positive. And this is this very interesting phenomenon of indolent T lymphoblastic proliferations that you can see in Castleman disease, particularly the hyaline vascular subtype. Important to know about and not to misdiagnose the patient as having a coexistent T lymphoblastic leukemia or lymphoma. Why this occurs, it's unclear, but certainly well described in patients, in particular with hyaline vascular Castleman disease. So another immunohistochemical study, although I said you don't need to do it, but can be quite helpful if present, is what I'm about to illustrate here. So here is CD3 highlighting the T cells in the interfollicular areas. The cells that are not staining, the blue and non-brown areas, are of course the B cells. And here's CD5, another T cell marker, but I think you can see quite clearly, or hopefully quite clearly, that there's sort of a fuzziness of positivity in the B cell areas. Here, there's nice crisp negativity of the B cells for CD3, but if you look in the CD5 stain, it's a bit more dusty looking. And in fact, there are subsets of B cells that are co-expressing CD5, something we'd more likely associate with, say, CLL, SLL, or even mantle cell lymphoma. But this, it can be seen in Castleman disease. The reactive, physiologic, non-clonal mantle cells in Castleman disease can sometimes overexpress CD5. You may see this by immunohistochemistry. You may see it by flow cytometry. Don't go down the tubes and misdiagnose a mantle cell or small lymphocytic lymphoma if you see this. One disease to exclude when considering multicentric Castleman disease is, of course, HHV8. And here you can see a follicle with a regressed germinal center, and scattered in the mantle zones are larger atypical cells, so-called plasmablasts, which when you do an HHV8 stain will light up these cells. And although these are called plasmablasts, suggesting they are cells that are pre-plasma cells, in fact, they are naive B cells. They do not evince somatic hypermutation. They have not transited the germinal center, and yet also interestingly, they're typically IgM positive and also lambda light chain restricted, which ordinarily one might say, oh, these cells are neoplastic, they are clonal, but in fact they are polyclonal. When you do gene rearrangement studies, they are polyclonal. And it's just an interesting observation as to whether the HHV8 is driving lambda differentiation, whether the HHV8 it somehow needs lambda to get into the B cells is an area of study. Here's another example of plasma cell variant now of a Castleman disease, showing clearly sheets of plasma cells, very non-specific finding, but a helpful criterion for diagnosing this form of Castleman disease. And another characteristic phenomenon, again, although non-specific, is quite commonly seen, and this is increased deposition of hemosiderin in the interfollicular regions of patients with the plasmacytic variant of Castleman disease. This was a nice study published last year that looked at the vascular components and distinguishing those in idiopathic plasmacytic lymphadenopathy from those in TAFRO, and then doing image analysis and quantifying what's going on. So looking in the interfollicular areas, the IPL variant is dominated by plasma cells, so there are physiologic vessels in the background, normal numbers. But you can see here, you don't even need image analysis or quantification to show that there's increased endothelial cells in the TAFRO form associated with hypervascularity. And not only that, the endothelial cells in TAFRO tend to be plump, whereas those in plasmacytic variant are physiologic flat endothelial cells. And in this paper, they used image analysis to enumerate the vascularity and use that as a criterion. The same group also looked at the vascularity now not within the follicle, in the interfollicular areas, but within the follicles. In IPL, the plasmacytic variant, you remember, associated with hyperplastic follicles, very few vessels. By contrast, in TAFRO, there is a prominence of vessels, and these vessels go into the germinal center and form these so-called whirlpools, another characteristic histologic feature of TAFRO that might be useful as a diagnostic criterion in the future. This is a very busy slide, but it's got a lot of important information, so I'll spend some time on it, distinguishing the key features of TAFRO type idiopathic multicentric Castleman disease. Again, thrombocytopenia as opposed to the usual thrombocytosis seen in the other forms. A for ascites, F for fibrosis or fever, R for reticular fibrosis or renal dysfunction, O for organomegaly. So the TAFRO at one end of the spectrum, often presenting acutely with cytokine storms. At the other end of the spectrum is MCD type, NOS type, often presenting with other features that may help distinguish it. And then the IPL form of Castleman disease, idiopathic multicentric Castleman disease. TAFRO form tends to occur more commonly in pediatrics. So if you look at the median age of patients with TAFRO, it's quite a lot younger than those with the other forms of IMCD. And allied to that, most cases of Castleman disease encountered in kids will be TAFRO more than the others. Another important facet about TAFRO is its similarity, and we'll talk about this in a bit more detail, with HLH and the need to distinguish it from HLH. Interestingly, about a quarter of patients from the Japanese studies with TAFRO do not have lymphadenopathy. And if they don't have lymphadenopathy, they don't have Castleman disease. The point is here that you don't necessarily diagnose Castleman disease every time you encounter TAFRO. This is kind of analogous to the scenario I mentioned in a much earlier slide with POEM syndrome. Not all POEM patients have Castleman disease. Similarly, not all TAFRO patients have Castleman disease. Another pointer towards the features you may encounter in TAFRO if you're doing laboratory studies or radiologic studies, adrenal involvement is frequently seen in this disease, which is an unusual feature and distinguishes it from the others. And if you're doing chemistry tests, alkaline phosphatase is elevated out of proportion to LDH in these patients. Moving to idiopathic multicentric disease, IPL, the plasmacytic variants, a major differential diagnosis there is IgG4-related disease. And certainly the histology can be similar in both of these entities, but there are a number of pointers towards idiopathic multicentric Castleman disease. There's less lymph node eosinophilia, which is something you may see in IgG4-related disease. Patients tend to be younger with Castleman disease. They're sicker with higher fever. They have higher CRPs and lower albumins and hemoglobin. They have less extranodal disease, which may be a feature of IgG4-related disease. And finally, if you look at the ratio of IgG4 over IgG in the serum, it's usually less than 19% in Castleman disease, but higher than that in patients with IgG4-related disease. And just to highlight, one of the features you may encounter in patients with NOS MCD is not uncommon involvement of the lungs with pulmonary nodules and interstitial thickening. So trying to portray in this busy slide some of the features that distinguish the three major types of idiopathic multicentric Castleman disease. As I alluded to previously, sometimes the clinical picture of TAFRO can look like HLH. And so when a patient presents with a cytokine storm, fever, cytopenias, hepatosplenomegaly, lymphadenopathy, renal dysfunction, how do you distinguish HLH from TAFRO? There's this paper that came out at the end of last year from a group of investigators looking at three markers in the serum: C-reactive protein, ferritin, and soluble CD25. And if the ferritin is elevated but less than 4,900, if the CRP is elevated above 80, if the serum CD20 soluble CD25 is elevated but less than 3,900, you are more likely dealing with a TAFRO. By contrast, the opposite levels are seen in patients with HLH. The ferritin is much higher, the CRP is not that elevated, and the soluble CD25 is much higher. So looking at those criteria, of course, in concert with the other pathologic features and clinical features, penetrating vessels there, and perhaps an attempt at forming a whirlpool, anasarcal fluid overload, fibrosis in the marrow, lymph node pathology is seen in TAFRO, whereas HLH, there's often underlying immune dysregulation. You may or may not see bone marrow hemophagocytosis, not a terribly specific finding. Lymph node biopsy to rule out lymphoma, this may, harken the presence of a underlying T-cell lymphoma. But with the looking at these three parameters in the blood, should be able to distinguish the two according to the study, highlighting the sort of multi-system complexity of HLH and Castleman disease is an understanding of where these abnormally elevated proteins come from. CRP elaborated from the liver, by the liver, ferritin from macrophages, and soluble CD25 from T cells. This Kaplan-Meier survival curve illustrates the important survival differences now between the three broad flavors of idiopathic multicentric Castleman disease. IPL patients tend to have the best survival of all. It's not fantastic, but the best survival of all. Patients with TAFRO have the worst survival, as illustrated in red, with the NOS patients somewhere in between. So important to distinguish these three flavors of multicentric idiopathic Castleman disease because of these very different outcomes. Also important to highlight that in addition to TAFRO having a worse outcome as compared with IPL, patients, as I mentioned in a previous slide, tend to be younger. They have a more rapid acute onset mimicking HLH, and they're just generally sicker patients, whereas patients with IPL can have chronic progressive lymphadenopathy. The challenges for the pathologist are multiple. The histopathology, although I've spent some time going through the features to be seen in Castleman disease, are non-specific and can be seen in the mimicking diseases, such as cancers, such as infections, and such as autoimmune diseases. So it can be very, very deceptive. And there are variable histopathologic findings. I've illustrated sort of the classical features, but some may predominate and some may be more specific than others. That can certainly be challenging. As a pathologist, you should never hesitate to request a repeat lymph node if you're unable to make the diagnosis with confidence. And even with an excisional lymph node, you may not be able to make the diagnosis with confidence. And although there are clinical correlates that I alluded to before with the pathology, UCD, hyaline vascular or hypervascular, and MCD with plasmacytic, and IPL with plasmacytic, and TAFRO with hypervascular, the proportion and distribution of these different histologic subtypes varies from subtype to subtype. So there's not a one-to-one association. It's become clear that it's very important to make a timely diagnosis and institute therapy as soon as possible in Castleman disease. But patients, as I'm sure you've encountered in your clinical practices, if you've seen patients with Castleman disease, they may cycle through a litany of different multiple specialties. Patient presents with non-specific flu-like symptoms and lymphadenopathy, may see a primary care physician, imaging and lab tests may be performed, and they may be referred to a multitude of different subspecialties. An infectious disease doctor would do infectious disease workup, rule that out. A rheumatologist would evaluate for autoimmune disorders, hopefully rule these out, or not hopefully rule these out, but in terms of the pathway towards making this diagnosis, rule them out. Ultimately, the patient may see a hematologist oncologist and be evaluated there. A lymph node biopsy may be performed, is often inconclusive initially, maybe because it's just too difficult to make the diagnosis, or because one's dealing with inadequate material, such as a core needle biopsy. Ultimately, an excisional biopsy is performed. Ultimately, a skilled pathologist familiar with this disease gets to evaluate the lymph node. Sometimes even a so-called expert hematopathologist may struggle. And so therefore there are panels that exist to review such cases and score independently and then in aggregate the diagnostic criteria to yield this challenging diagnosis. This slide illustrates from the study that I alluded to earlier from 2022, looking at insurance claims, looked at inpatient hospitalizations and emergency department casualty visits for patients with idiopathic multicentric Castleman disease within the first few years of their initial diagnosis. So prior to being diagnosed, roughly a third of patients got admitted to hospital and spent 5 or more days in hospital. Almost a half of patients went to casualty for their symptomatology. Within the first year of the diagnosis, there was a halving of the number of patients that were hospitalized for that long, a slight reduction in casualty visits, but in the second year, a much more dramatic drop in the number of hospitalizations required, a much more dramatic drop in patients visiting a casualty once the disease had been diagnosed and therapy had been initiated. It's also sometimes underappreciated that patients with Castleman disease develop morbidities in other systems and organs in the body that you might not have anticipated. And that's illustrated in this graph here, in which patients with Castleman disease with the solid lines are compared with age-matched controls. And in green shows that in particular, patients with Castleman disease much more likely cumulatively to encounter renal dysfunction, to encounter respiratory dysfunction, and to encounter thrombotic episodes than in the age-matched general population. There's also an increased prevalence of neoplasms in patients with idiopathic multicentric Castleman disease. Not entirely clear why this is the case. What this study highlighted is, in fact, there's a high incidence of myeloid neoplasms and not acute myeloid leukemia, but more MDS, myelodysplastic syndrome, and myeloproliferative neoplasms as compared with age-matched controls, and also a more likely development of solid tumors, in particular lung cancer and carcinoma of unknown primary in patients with multicentric Castleman disease. If untreated, patients will die from the disease. They die for a number of different reasons. It's illustrated in this small study from about a decade ago. Organ failure, sepsis, malignant disease are the things from which patients with multicentric Castleman disease can demise from. As I mentioned in an earlier slide and from an earlier study, about 1/3 of patients will die within 5 years of the diagnosis. So it's a lethal disease in a proportion of patients, and the outcomes of idiopathic multicentric Castleman disease are poorer than some cancers, such as stage 2 colon cancer, breast cancer, and some types of lymphoma. Although I'm not really qualified to talk about therapy, that won't stop me from just mentioning what is out there in terms of the therapeutic options for treating idiopathic multicentric Castleman disease. Most of the current therapy is targeted at anti-inflammatory and immunomodulatory pathways. So, of course, targeting cytokines has been tried with variable success, in particular targeting interleukin-6, but other cytokine-directed therapies have also been met with some success as sort of second or third line therapies, targeting TNF-alpha or interleukin-1, targeting signaling pathways within the cells, mTOR inhibitors, JAK inhibitors, BTK inhibitors have been used, proteasome inhibitors, steroids, of course, although not in isolation, but together with other therapies, and immunomodulatory drugs, such as thalidomide and other such lenalidomide type drugs. And in some patients, it's necessary to give cytotoxic anti-lymphoma type therapy to control the disease. May consist of multi-agent chemotherapy, might consist of anti-B cell therapy such as rituximab, which has been used in particular in patients with HHV-8 related disease with other agents, but is sometimes used or necessary in multicentric, idiopathic multicentric Castleman disease. Recently published, I don't know if they've been published in full form yet, but in draft form are the NCC guidelines for the treatment of Castleman disease. And again, I have no authority really to talk about this, but just shows some of the first line drugs that are recommended, starting off with the interleukin-6 inhibitors, but a multitude of other drugs or drug combinations that I alluded to on the previous slide. Some of the other agents I also mentioned on the previous slide, but here are the drug names targeting specific molecules, cytokines, intracellular signaling, proteasome inhibitors, or myeloma therapy for patients with POEMS syndrome-related Castleman disease. So to conclude, in terms of the summary, in terms of background, we hopefully now know that Castleman disease refers to a really very heterogeneous group of disorders that share these variable histopathologic features of lymph nodes. Patients with idiopathic multicentric Castleman disease are difficult to identify, not only clinically, but also pathologically, but they reflect a potential life-threatening disorder which should be treated at the point of diagnosis. The pathogenesis is complicated. It's driven by a cytokine storm with an unknown initiator. And yes, human interleukin-6 is a critical driver of the disease, but serum IL-6 is not a reliable diagnostic marker or useful to monitor the disease. And certainly other cytokines and chemokines are also important in the pathogenesis of the disease. The diagnosis ideally should be made immediately and accurately, of course, but that's not always the case. To help facilitate the diagnosis, diagnostic criteria have been developed through this international expert consensus to provide a framework for the diagnosis. The diagnosis requires, perhaps more so than just about any other condition that pathologists and clinicians encounter, is a multidisciplinary approach and talking about the patients and the pathology to yield a diagnosis. Excisional lymph node biopsies, in my opinion, are mandated and are not just recommended to either diagnose or exclude idiopathic multicentric Castleman disease. It's highly important, of course, to treat the patient sooner rather than later. They have a poor outcome. They have a chronic disease that tends to progress in the absence of appropriate therapy, and they can lead to severe symptoms, organ dysfunction, and death. But importantly, although there are drugs that have been quite successful, not all patients respond to anti-IL-6 therapy. I just wanted to conclude by showing a sort of composite slide of the pathology of Castleman disease from this very nice recent review published by Luke Chen from Dalhousie in Nova Scotia in Canada, illustrating the plasmacytic hyperplasia seen here, illustrating the abundance of plasma cells seen here, illustrating the mantle cell hyperplasia, not as nice a picture, I don't think, as the one I showed earlier, but with regressed germinal centers. Here's a better illustration, perhaps, of mantle cell hyperplasia and onion skinning, a regressed germinal center with FDC hyperplasia, thickening of vessel walls, hypervascularity, hyalinization of the increased numbers of vessels, and then a penetrating vessel, so-called lollipop sign. And if you've got all of those features in the lymph node, it's really straightforward to make a diagnosis. Unfortunately, not every patient's lymph node with Castleman disease has read this textbook or this review article, and hence the difficulty encountered in clinical practice. That's the end of my lecture. Thank you very, very much for your attention. I'll be happy to answer questions.
Thanks, Prof. Bagg. That was very complex but very thorough, and makes me somewhat glad that I don't look at lymph nodes on a daily basis.
Yeah.
It looks like quite a hard diagnosis to make. If anyone has any questions or comments, please feel free to unmute yourself and ask away. Otherwise, you can post in the chat box. I see that there is one comment from Jacques Malherbe saying in our setting, HHV8 multicentric Castleman disease is by far the dominant form, and that he's only seen a single case of idiopathic multicentric Castleman.
Understandable. Yeah.
Yeah. I wonder how many diagnoses we just aren't making. It's quite a finicky. If you don't have this, lollipop signs and the textbook signs, how
Yeah.
easily the diagnosis is made.
Yeah, and I think that's a problem encountered no matter where you are. But just an awareness and at least to consider it in the differential diagnosis, I think is key.
Yeah, definitely. And in terms of the plasma cells, presumably those would be polyclonal in the background.
Yes, definitely.
Let me just check that I'm not missing anything. Doesn't seem like there are any pressing questions.
All right.
You covered it far too thoroughly.
Or far too confusingly is the other alternative
We've got a
interpretation.
we've got a question here saying, how important is HIV in this setting?
Very important. I mean, in a patient with HIV, first of all, the lymph node changes we see in Castleman disease can be seen in HIV. So it's important to rule out HIV when one is considering a diagnosis of idiopathic multicentric Castleman disease. And obviously, if you've got HIV, you've got to vigorously evaluate for HHV8 as driving the disease. So important as both a mimicker as well as diagnosing a subtype of idiopathic multicentric Castleman disease.
Other questions or comments? Can't see anything else popping up.
Okay.
Everyone's just saying thank you.
All right. Thank you, everybody. Thank you for joining.
There's one other question. Given the diagnostic implications, should LANA testing or LANA staining be standard in all suspected cases of Castleman's, or reserved
Absolutely.
for those with features suggestive of HHV8?
Yeah, I mean, there certainly are features of HHV8 more likely to see the plasma cell expansion. You might see those plasmablasts in the expanded mantle zones, but because it's such a devious disease, I think each and every time one encounters or considers a diagnosis of Castleman disease, I think it's important to do an HHV stain, a LANA stain, and as you know, the therapy for HHV8 positive multicentric Castleman disease is fairly well defined, giving Rituxan, giving antiviral sometimes, giving the doxorubicin. So I think it's very important to either diagnose, obviously, and not miss it, so to rule it out. So yes, I mean, if you've got an isolated unicentric Castleman with classic histopathology of hyaline vascular type, I think it's unlikely, but you never know. This old school association of the pathology with the clinical subtype has certainly been blurred in recent studies. So I wouldn't hesitate to do LANA stains.
Yeah, I see they're also commenting that it would be interesting to know in South Africa how many idiopathic versus HHV8 cases we
Yeah,
see, because
I think
HHV8 seems to be quite common.
yes. No, I think I
Yeah.
mean I'm not. If such studies haven't been done, it may be worth doing such studies. And if you've got cases that you want to have evaluated, certainly there are groups that I'm associated with, the Castleman Disease Cooperative Network, that might be interested in helping facilitate such studies. If people are interested, can certainly contact me. Um,
Thanks.
yeah, and I
And
think
a
there
lot
is
of
certainly there
kind
is
of
already. I mean, there's some already well-known geographic differences between sort of what one encounters in so-called Asian or East Asian populations versus so-called Western populations and the distribution. Whether that's just real or whether it's awareness is unclear. But certainly both TAFRO and IPL were first described in the Japanese literature and took a while to become recognized in the so-called Western literature. Whether there's a higher frequency there is unclear, or there's just a better awareness or better pathologists there than there are elsewhere in the world. We don't know. So, but there are apparent geographic differences.
yeah, definitely something worth looking at in our setting.
Yeah.
Got lots of audience members. Maybe someone will take that up.
Yeah.
Um, and then lots of comments to say thank you, fantastic presentation. Someone else said that you rock. And then there's one other question: with the status of our health system and how sick these patients are, it's quite possible that some patients die before diagnosis. That is obviously very plausible.
Sorry, I didn't. I was distracted by a private comment from someone. So we got the general comments. I'm also getting some private comments. I wonder if I should read the private comments aloud. Sorry, what were you saying, Lauren?
Just there was another comment saying, with the status of our health system and how sick these patients are, it's quite possible that some patients die before diagnosis.
I think so, and I think that also happens in, where there may be better resources, just because it's a disease that can be tough to recognize. And I think the issue also, just as an aside, is that misdiagnoses are what we're sort of talking about, but also certainly in the groups with which I work, overdiagnosis is a problem. A lot of cases that are referred to us with probable Castleman disease are not Castleman disease. So that's the flip side as well, and just that attests to the difficulty with the diagnosis.
Definitely. Any last comments or questions? Anyone's welcome to unmute themselves or continue private messaging. All right, I think then with that, we can wrap up the session. Thanks again, Adam, for such an amazing presentation, really. Very,
Thanks.
very interesting.
Thanks for hosting, Lauren. Good to see you all. Thank you.
Yes, perfect. Thanks,
All right.
everyone. Have a lovely Monday.
Cheers. Bye-bye.